but we are going to switch gears now to Dr. Gretchen Glaser. This is her first time being a member of our faculty here for our annual Let Everyone Know Arts of Healing Conference, and it's really an honor to have you. Dr. Glaser is the Associate Professor and Vice Chair at Mayo Clinic in the Division of Obstetrics and Gynecology. She's a gynecologic oncologist herself, and she is going to be speaking to us about COVID, clinical outcomes in patients with COVID-19 and gynecologic cancers. So welcome.
Good morning, and thank you for allowing me to speak with you today about clinical outcomes in patients with COVID-19 and gynecologic cancer. I have no financial disclosures, and I will not be discussing any unlabeled or investigational uses of any drugs or devices. I think it's safe to say that not a single person in our world has gone untouched by COVID-19 over the last 3 years. Even the fact that we're able to gather virtually for this great conference today was brought about by the inability to gather in person for so long and the inevitable adaptations that occurred because of that. Just some examples I've illustrated here of the things that changed during the pandemic was our ability to gather in person with family and friends, our ability to hold big events like graduations, weddings, even funerals, our ability to travel in any vessel that keeps people close together like airplanes or ships, and even our ability to get appropriate medical care at the right time. Patients who already had significant medical problems at the beginning of the pandemic were possibly even more affected than those who did not, and this includes gynecologic cancer patients. The World Health Organization, or WHO, declared the outbreak of novel coronavirus COVID-19 a global pandemic on March 11, 2020. And since then, there have been 671 million cases and 6.7 million deaths worldwide as of mid-January. In the US, we have had over 103 million cases and 1.1 million deaths during the same time frame. In the entire US, approximately 81% of the population received at least one dose of COVID vaccine, and 68% have received at least one full series. The symptoms and severity of COVID-19 vary widely, with some people not even knowing they have COVID-19, others having something akin to a common cold, and still others needing hospital and even intensive care unit level care. We know from several studies that these symptoms are worsened with increasing age and also with other conditions that people sometimes have at the same time as their COVID-19 diagnosis. Some of these conditions can include high blood pressure, diabetes, and heart disease. Blood type may also play a role in COVID-19 infection and severity. We know that patients with gynecologic cancer may come from all different age groups and have varying other non-cancer conditions, so they may already be in a higher risk group from COVID-19. When we look at cancer specifically, a study that combined and analyzed several different studies, something called a systematic review, of patients with both cancer and COVID-19, found that even a higher percentage of people with cancer may die of COVID-19 if they become infected. Of all the people who get COVID-19 worldwide, between 1% and 8% will die of their disease. In the US, this number is about 1.6% of patients who contract COVID-19 will die of their disease. This was especially true in the earlier days of COVID-19, before a high proportion of the population had received COVID-19 vaccines and before there were good treatments available. The treatments for gynecologic cancers, for example, major surgery, chemotherapy, radiation therapy, among others, could further exacerbate the risks of having cancer and COVID-19 at the same time. In addition, delay or alteration of treatments for patients with gynecologic cancer because of the necessary reduction of many healthcare services during the early days of the pandemic potentially further complicated this picture and a patient's cancer course. We all know that the more you know, the better you can cope with any situation, and this is no different for the combination of gynecologic cancer and COVID-19. Understanding the complex interplay of gynecologic cancer and COVID-19 infection will allow patients and their providers to approach treatment plans with nuanced care. So, how do we acquire that knowledge? By looking at lots of patients with both gynecologic cancer and COVID-19 in lots of different parts of the country and seeing how they do and what the difficult and maybe not so difficult parts of their COVID-19 and cancer courses are. I was fortunate enough to be part of a large team performing just such a study, and I'm excited to be able to tell you about it today. From 2020 to 2022, the Society of Gynecologic Oncology, which is a global, diverse, and inclusive society whose goal is to elevate the entire world of gynecologic oncology, formed a COVID-19 task force, which focused on provider and patient education, as well as investigation into important research and practice questions, such as this one. I will also talk about what other researchers have found at their own institutions or as part of multi-institutional studies. While the studies I will discuss all focus on patients with gynecologic cancer, there are a wide range of cancer types that go into these gynecologic diagnoses. And we want to make sure that we are looking at diverse groups of patients in order to draw meaningful conclusions. I will highlight the findings of patient type from our Society of Gynecologic Oncology, or SGO, study, as they are very similar to the studies I will discuss, with the exception of some of the other studies focused on one institution or one geographic area. In our SGO study, physicians from 7 different centers in 6 different states across the US were able to include their patients. And you can see here that there is good geographic representation across the country. Data was available for 348 patients, with almost all practices describing themselves as urban and 81% in academic tertiary care centers, or another way to say that is a large academic hospital. The average age of patients in our study was 60.5 years, which is consistent with other studies of patients with gynecologic cancers. Race and ethnicity are distributed as shown. Only 11% of patients worked in a healthcare setting, and 71% had a good performance status. That means that they're not hindered much at all physically in order to do all of the things that they need and want to do on a day-to-day basis. This information is really important because we know that patients with a poor performance status or inability to do their day-to-day activities very well can struggle more from both gynecologic cancer and COVID-19. And this could skew our outcomes if a large section of our patients had significant physical limitations. The most common pre-existing conditions that patients in our study had included high blood pressure, obesity, and diabetes, with smaller numbers of patients having other conditions such as immune suppression, autoimmune disease, asthma, and heart disease, to name a few. 62% of patients had 2 or more non-cancer chronic conditions at the time of COVID-19 diagnosis. This information is important because we know that patients with conditions such as high blood pressure, obesity, and diabetes, and some immune conditions have worse outcomes from COVID-19 infection. Gynecologic oncology diagnoses followed an expected distribution, so we saw about the percentage of cases in each group that we normally would. About 33% of our patients had low-grade endometrial or uterine cancer, 22% had high-grade ovarian cancer, 14% had high-grade endometrial cancer or cervical cancer, and 4% had vulvar cancer. The remainder were divided into rare gynecologic cancer types. 36% of patients diagnosed with COVID-19 had active cancer at the time of diagnosis, and 24% were receiving active anti-cancer therapy. The most common treatments being administered were surgery at 43% and chemotherapy at 32%, with a smaller number in the radiation therapy, targeted therapy, hormone therapy, and immunotherapy groups. 14% of patients were receiving 2 or more therapies at once. For example, simultaneously getting chemotherapy and radiation therapy for cervical cancer. The first question that we wanted to answer is, do our patients with gynecologic cancer who are actively undergoing cancer therapy experience a delay in their cancer therapy as a result of COVID-19 infection? And does this have any bearing on their long-term cancer outcome? In our SGO study, we found that of patients who were actively undergoing cancer therapy at the time of their COVID-19 diagnosis, approximately 25% had a delay of treatment and another 3% had their therapy discontinued altogether. In this group of patients, chemotherapy was the most frequently delayed treatment, 60% of those delayed, followed by surgery, 36% of those delayed. Another study performed at 3 hospitals in New York City found that 39% of patients with gynecologic cancer experienced a delay, change, or cancellation to their cancer treatment during the first 2 months of the pandemic. Similar to the SGO study, systemic treatments such as chemotherapy and surgery were most frequently delayed. In another study based in St. Louis, Missouri, referrals to gynecologic oncology dropped by 32% during the early pandemic, likely due to a complex cascade of events, such as patients not being able to get in for care. While the studies that were performed in the early pandemic did not specifically show differences in cancer outcomes between patients who did and did not undergo treatment delays, we know from previous studies that treatment delays do decrease overall survival in patients with cancer. One example of this is in a study from 2020 showing that across several cancer types, including gynecologic cancer, there was a significant decrease in survival for every 4-week delay in treatment. In another study from 2015, looking specifically at patients greater than or equal to 65 years of age who had stage 2 through 4 ovarian cancer, any delay in their chemotherapy was associated with a decrease in overall survival, even when controlling for other significant things like age, stage of disease, amount of disease remaining after surgery, and number of cycles of chemotherapy received. So from this information, we know that we want to try to avoid delays in cancer therapy and that COVID-19 can cause necessary delays in treatment. In the early pandemic, these delays may have been caused not only by a patient's need to recover from illness before receiving more cancer therapy, but also by the inevitable and necessary changes that happened in healthcare systems, shortage of anti-cancer medication, and need for quarantine, even when someone with COVID-19 is feeling fairly well. Our next question, after what effect will COVID-19 have on gynecologic cancer, is what effect will gynecologic cancer have on COVID-19 in patients who have both conditions? Will the symptoms be worse? And what about the risk of needing to be hospitalized or spend time in the intensive care unit? Finally, does having a gynecologic cancer when a person is diagnosed with COVID-19 increase their risk of death from respiratory illness? In our Society of Gynecologic Oncology study, 20% of patients with gynecologic cancer and COVID-19 required treatment with supplemental oxygen therapy, and 29% were hospitalized. 5% were in the intensive care unit at some point during their hospital admission. In another study published from a 6-hospital consortium in New York City, 55% of patients with both COVID-19 and gynecologic cancer were hospitalized, and of those hospitalized, 68% had to have some sort of respiratory intervention, whether that was just some oxygen via the nose or included more invasive methods such as intubation. The next question we had was, what is the risk of dying from COVID-19 complications if a patient also has gynecologic cancer? In our SGO study, 8% of patients who were hospitalized with COVID-19 died of their disease. In the study I mentioned, looking at the 6 hospitals in New York City, 14% of patients hospitalized with COVID-19 and all of the patients who eventually had to have a breathing tube placed died of complications of COVID-19. In a follow-up study to the one performed in New York City, 17.6% of patients with COVID-19 and gynecologic cancer died of COVID-19 complications. These are obviously very striking numbers, especially since the SGO study spanned the time before and after the introduction of vaccines. The last question that was extremely important to us was, what is the effect of various healthcare disparities on the outcomes of patients with both COVID-19 and gynecologic cancer? This could include outcomes like hospitalization, COVID-19 disease severity, delay of cancer treatments, and even death. In our SGO study, we found that non-white race was associated with a nearly 4-fold increase in the odds of hospitalization, which can also be a marker for disease severity. We did not find a significant difference in delay or discontinuation of treatment between races, and the difference in mortality, while did look slightly higher in non-white patients, did not reach a level which we could call statistically significant in medical literature. It's important to note that while our study did not show a difference in delay or discontinuation of cancer treatment, we know that this has been shown to vary by patient-identified race for many years and is a facet of cancer and COVID-19 care which will benefit from further attention. Another study published in the New England Journal of Medicine, a very prominent medical journal, came out of Ochsner Health System in New Orleans, Louisiana, and found that while Black patients comprised 31% of the total population of patients with COVID-19, this group also counted for 77% of hospital admissions. A systematic review of 52 studies and data from the Center for Disease Control found increased mortality or death from COVID-19 in non-white patients, but no difference in the proportion of patients dying from COVID-19, indicating that the cause is likely related to a complex confluence of exposure and healthcare access. This is a topic that needs more study as well, and there are some interesting tools to address this complex disparity. For example, the Harvard Public Health Disparities Geocoding Project. Another aspect of healthcare disparity arises in issues like rural healthcare and financial toxicity or difficulty with finances during treatment of care for patients. In 2021, a group out of Canada published a study showing that patients with COVID-19 and gynecologic cancer were over 9 times more likely to have a surgical treatment modification and almost 2 times more likely to have a surgical delay in the treatment of their gynecologic cancer if they were at a public versus a private hospital. Along a similar theme, a group in New York City found that during the early pandemic, patients with gynecologic cancer and lower income levels had an increased risk of financial distress, cancer worry, and anxiety. In the 3 years since the start of the pandemic, many advances have been made in vaccination for and treatment of COVID-19. In a late 2021 study published in the Journal of the American Medical Association, it was shown that hospitalization for COVID-19 was significantly associated with a decreased likelihood of vaccination, as well as disease progression, need for mechanical ventilation or a breathing tube, and death. This was also consistent with so-called breakthrough infections after a vaccine being less severe than infections acquired without a vaccine. Another study published in the New England Journal of Medicine in March of 2022, looking at patients in North Carolina, also showed that the risks of hospitalization and death were reduced by COVID vaccination. Since late last summer, boosters are now available, which cover the Omicron variant in addition to the original strains. These are the current CDC recommendations for booster vaccines, which have been in place since the bivalent booster containing protection against the Omicron variant came out in September of 2022. It is that everyone age 5 and older who has not received the bivalent booster and for whom it has been at least 2 months since your last dose is eligible to get this new booster. More good news has come in the form of treatments for COVID-19, which are given to patients with COVID-19 based on an assessment of their symptoms and level of risk of progression to severe disease. Most healthcare systems now have a well-organized system to help patients get these treatments as quickly as possible once they start having symptoms and are diagnosed with COVID-19. To be the most effective, these treatments should be started within days of a developing symptoms. As we move forward with COVID-19 as part of our daily lives for the foreseeable future, we need to think about the best way to integrate optimum cancer care that minimizes delays in the landscape. Knowing that knowledge is power, we want to keep gaining knowledge about the interplay of COVID-19 and gynecologic cancer so that we can best plan approaches and treatments. A majority of the broad cancer and COVID-19 trials that have been done included few gynecologic cancer patients. And by both increasing our participation in those studies and continuing to study our own group exclusively, we will be able to increase that knowledge. Another great way to integrate cancer care into a world that also struggles with COVID-19 is to arm ourselves with this information about preventing severe disease. Make sure we keep up with our recommended vaccines and boosters for COVID-19 and encourage our family, friends, and colleagues to do the same. At the same time, making sure we keep tabs on any other chronic medical problems and optimizing their treatment will be key to preventing the kind of severe disease that can lead to cancer treatment delays, changes, or discontinuations. Of course, remaining aware of the pandemic as it pivots and following recommendations for prevention and treatment will be an important part of our plan moving forward. At the forefront of all future discoveries must also be investigation into the causes and possible solutions for healthcare disparities for both COVID-19 and cancer care. Thank you to the program committee for inviting me to speak today, to SGO for their support of our COVID-19 and gynecologic cancer registry and study, to all of our collaborators for this project, and of course, to all of you for coming to this great conference today. Thank you.